Acute aortic syndromes. Rajesh KF. Acute aortic syndromes consist of three interrelated conditions with similar clinical characteristics. Aortic dissection, intramural hematoma, penetrating aortic ulcer, Erdmalar, Alfonso F., Boileau C., Dershow, Eber B., Haybrick A., et al. Erdmalar, Alfonso F., Boileau C., Dershow, Eber B., Haybrick A., et al. Diagnosis and management of aortic dissection. Yerhard J. 2001 22 to 1642-81. Aortic dissection. Most common aortic catastrophe. Incidence, 5 to 30 per 1 million people/year. Primary tear in aortic intima with bleed into disease media. Rupture of vasa vasorum, hemorrhage in aortic wall with subsequent intimal disruption. Most ascending aortic dissections begin within a few centimeters of aortic valve. Most descending aortic dissections have their origin just distal to left subclavian artery. DeBakey classification. I. Ascending aorta, greater than arch plus / descending aorta. 2. Ascending aorta only. 3. Descending aorta. 5. Limited to descending thoracic aorta. 5. Extending below diaphragm. Stanford classification. Type A. Affect descending aorta, regardless of site of origin. Type B. Do not affect descending aorta. Classification. Based on time of onset of initial symptoms to time of presentation. Acute dissection less than 2 weeks. Subacute between 2 and 6 weeks. Chronic greater than 6 weeks. Behave like aneurysm. Rupture is a risk. Malperfusion is rare. Risk factors. Hypertension, 75%, genetically triggered, Marfan syndrome, bicuspid aortic valve, 5 to 10 times risk, Loeys-Dietz syndrome, hereditary thoracic aortic dissection, vascular Ehlers-Danlos syndrome, congenital diseases or syndromes, coarctation of the aorta, Turner syndrome, dissection at small aortic dimensions, tetralogy of atherosclerosis, penetrating atherosclerotic ulcer. Trauma, blunt or iatrogenic. Catheter or stent. Intra-aortic balloon pump. Aortic or vascular surgery. Motor vehicle accident. CABG or AVR. Cocaine use. Inflammatory or infectious disease. Giant cell arteritis. Takayasu arteritis. Basic disease. Aortitis. Syphilis. Pregnancy, typically in 3rd trimester. Patients less than 40 years are less likely to have HTN 34%, and more likely to have Marfan's syndrome, bicuspid aortic valve, or prior aortic surgery. IRAD registry. Marfan syndrome Ghent criteria. Cardiovascular system major criteria: dilation of ascending aorta, aortic dissection minor criteria, MVP dilation of MPA, premature mitral annular calcification, less than 40 years, descending thoracic or abdominal aortic aneurysm less than 50 years, CVS involvement 1 minor criterion. Ocular system major criterion, ectopia lentis skeletal system major criterion, presence of at least 4 of the following: pectus carinatum, pectus excavatum requiring surgery, reduced US to LS ratio, .85 to 0.95, or arm span to height ratio greater than 1.05, wrist and thumb signs scoliosis greater than 20 degrees or spondylolisthesis, reduced extension of elbows, less than 170 degrees, medial displacement of medial malleolus causing pes planus, pertusio acetabuli of any degree. Marfan syndrome Ghent criteria. Index case, major criterion: 2 systems and involvement of a 3rd system. Family member, 1 major criterion in an organ system and involvement of a 2nd organ system. Revised Ghent criteria. J. Mudgena 2010 47, 476 to 485, Loeys-Dietz aneurysm syndrome. Autosomal dominant. Mutations in TGFBR1 or TGFBR2. Arterial tortuosity, hypertelorism, bifid or broad uvula, cleft palate. Soft, velvety skin and easily visible veins. Aortic dissection and aneurysm involving branch vessels. Familial thoracic aortic aneurysm and dissection. Autosomal dominant disorder. Mutations in various genes including ACTA2, MY11, TGFBR1 and TGFBR2, FBN1. Thoracic aortic aneurysm and dissection. May be associated with PDA, cerebral aneurysm, Bavor livido-reticularis, vascular Ehlers-Danlos syndrome, type 4. Autosomal dominant. Mutation in gene COL3A1. Abnormal type 3 procollagen synthesis. Hyperflexible fingers, hyperlucent skin with visible veins, easy bruisability and varicose veins. Risk for spontaneous arterial dissection and rupture, often in medium-sized arteries. Clinical appearance of our patient. Note the translucent skin with visible underlying vasculature, slightly extensible skin, acrosuria, small joint hypermobility, characteristic physes, ecchymosis on the legs, genu-valgum, elongated upper extremities, and dorsal kyphosis. Aortic dissection clinical presentation. Usual ages 6th or 7th decades of life. Chest pain or back pain or both. Most severe at its onset. Migratory pain. Ripping, tearing, stabbing, or sharp quality. Patients on steroids and Marfan syndrome prone for painless presentation, 6.4%. High-risk examination features. Loss of peripheral pulse. SPP limb differential greater than 20 mm Hg. Focal neurologic deficit. New murmur. International Registry of Acute Aortic Dissection, IRAD, physical findings of 591 patients with type A aortic dissection. Most type B dissection are hypertensive on presentation. Type A dissection may present with normal BP or hypotension. Loss of peripheral pulse are reported in 10% to 30% of acute dissections. May be intermittent dynamic movement of dissection flap. Dynamic obstruction. Aortic regurgitation in 40% with acute type A dissection. Mechanisms of R. Malcoaptation of aortic leaflets, dilation of aortic root and annulus. Distortion of alignment. Aortic leaflet prolapse. Prolapse of intimal flap across aortic valve. These mechanisms include dilatation of the aortic root and annulus. Figure 5a, pressure of a false lumen on one cusp causing asymmetrical cusp coaptation, Figure 5b, flail of an aortic cusp. Attributable to annular support disruption. Figure 5c, and prolapse of a mobile intimal flap through the aortic valve. Figure 5d. 4. Neurologic manifestations. Most common in dissection type A. May dominate clinical presentation. Neurologic syndromes include persistent or transient ischemic stroke, spinal cord ischemia, ischemic neuropathy, hypoxic encephalopathy, syncope reported in 13% of patients in IRAD. Indicated development of dangerous complications. Acute hypotension, cardiac tamponade, 10% of acute type A dissections, or aortic rupture. Cerebral vessel obstruction or activation of cerebrobarboreceptors, vascular insufficiency. Renal artery -5% to 10%. Renal ischemia, infarction, renal insufficiency or refractory hypertension. Mesenteric ischemia or infarction in 5%. Extension iliac arteries acute limb ischemia. Acute myocardial infarction. flap causing malperfusion of coronary artery. Occurs in 1% to 7% of acute type A dissections. RCA is most commonly involved. Left-sided pleural effusion. Usually related to inflammatory response. Acute hemothorax. Chest radiography. Widening mediastinum, 80% to 90% of cases, 83%, type A, 72%, type B. Obliteration of aortic knob. Displaced intimal calcification, greater than 5 mm, calcium sign 20%. Displacement of tracheotorite. Distortion of left main stem bronchus. Pleural effusion, more common left-sided. Cardiomegaly. Normal in 12% to 15% of cases. D-dimer levels. Rise in acute aortic dissection as in pulmonary embolism. Level greater than 1,600 nanograms per milliliter within first 6 hours, positive likelihood ratio of 12.8 for dissection. In first 24 hours after symptom onset, D-dimer level less than 500 nanograms/ml has negative predictive value of 95%. Imaging 1 established presence of Adder variant, IMH, POW. 2 location of the dissection, type A, type B. 3 anatomical features. Extent of dissection. B sites of entry and re-entry. C false lumen patency, partial thrombosis, thrombosis. 4 complications of dissection. A type A. High aortic regurgitation. 2 coronary artery involvement. 3 pericardial effusion/hemopericardium. B aortic rupture or leaking. C branch vessel involvement. D malperfusion. Contrast enhanced CT most commonly used. Sensitivity and specificity of 95% to 98%. ACG gating or multi-detector scanning eliminate pulsation artifacts. Intravenous contrast is necessary to visualize true and false channels. Visualize hemopericardium, aortic rupture, and branch vessel involvement. MRI. Sensitivity of 98% and specificity of 98% with diagnostic odds ratio of 6.8. Capable of multiplanar imaging with 3D reconstruction. Seen MRI visualized blood flow, differentiating slow flow and clot and DAR. MRI detect and quantify aorta and branch vessel morphology. TTE. 78.3% sensitivity and 83.0% specificity for diagnosing proximal dissection. 2 lumens separated by flap. T. Accurately visualize entire thoracic aorta, sensitivity 98.0%, specificity 95.0%, diagnostic odds ratio 6.1. 2 lumens separated by flap. Visualize coronary ostia. R. Pericardial effusion. LV and RV function. May not adequately visualize distal ascending aorta and aortic arch. Aortography identify intimal flap, true and false lumen. Thickened wall, thrombose false lumen. R. Branch vessel involvement. Diagnostic accuracy 90 to 95%. 5 to 10% false negative rate. Thrombose false lumen. Simultaneous opacification of both lumens. Mrs. IMH. Risks of procedure. Comparative study with non-helical CT, 0.5 Tesla Mr. and T showed 100% sensitivity for all modalities. Better specificity of CT, 100%, than for T and Mr. False negative studies can occur. She got T, Wajima Z, Abfil CC, Eno 8T, OE diagnostic accuracy of transesophageal echocardiography, helical computed tomography, and magnetic resonance imaging for suspected thoracic aortic dissection. Archintern Med. 2006 166 to 1350-6. Initial management. For beta blockade target HR of 60 per minute or less low, C. Esmolol initial bolus of 500 microgs/kg and continuous infusion of 50 to 200 microgs/kg per minute. Labetalol initial dose of 20 mg for over 2 minutes and 40 to 80 mg for every 15 minutes, max 300 mg, continuous infusion 2 to 8 mg per minute. Propranolol and metoprolol-4 oral. BB's blockers compensatory tachycardia and acute AR. BB action. Cs to BB non-dihydropyridine CCB low, C. For diltiazem 0.25 mg/kg over 2 minutes greater than infusion 5 to 15 mg per hour. SPP greater than 120 mm Hg after adequate HR control Arche and or other vasodilators 4, low, C. Should not be initiated prior to rate control, reflex tachycardia increase aortic wall stress, low, C. 4 sodium nitroprusside, most established agent, rapidly titratable, 20 microg per minute, with titration to 0.5 to 5 microgs/kg per minute. Renal insufficiency or prolonged use cyanide toxicity. 4 enalaprilat, nitroglycerin, nicardipine, nitroglycerin, phenolidopam. Refractory hypertension, consider renal artery hypertension due to dissection causing renal malperfusion. Appropriate analgesia, opiate. Surgical therapy acute type A aortic dissection. Retrograde dissection into ascending aorta. Surgical therapy and or endovascular therapy. Acute type B aortic dissection complicated by visceral ischemia, limb ischemia, rupture or impending rupture, aneurysmal dilation, refractory pain. Medical therapy uncomplicated type B aortic dissection, uncomplicated isolated arch dissection. Goals of surgery: excise and demoltier. Obliterate false channel by oversewing aortic edges. Reconstitute aorta, usually by placing a Dacron interposition graft. Type A aortic dissection. Replace affected ascending aorta with or without aortic arch with prosthetic graft. In-hospital mortality 15 to 35%. Proximal extension or dissection to aortic valve or ostia of coronary arteries may require replacement or resuspension of aortic valve, 24% or coronary artery bypass, 15%. Valve sparing David or Yacoub procedures, AVR are required if annular supports of leaflets damaged, composite graft or homograft, AVR required if aortic root greater than 5 cm. Modified Bindle's operation. Preoperative prediction model of surgical mortality risk. Variable. Overall type A, %. Among survivors, %. Among death, %. Coefficient. Score assigned. P-value. Odds ratio, death, 95% C. Age greater than or equal to 70 years. 27.3. 24.1, 37.4, 0.68, 0.7, less than 0.01, 1.98, 1.19 to 3.29. History of aortic valve replacement. 4.5, 3.8, 6.6, 1.44, 1.5, 4.21, 1.56, 34. Presenting hypotension, shock, or tamponade. 28.8, 22.4, 49.0, 1.17, 1.2, 3.23, 1.95 to 5.37. Migrating chest pain. 13.8, 12.1, 19.3, 0.88, 0.9, 2.42, 1.32 to 4.45. Preoperative cardiac tamponade. 15.5, 11.7, 28.2, 0.97, 1.0, 2.65, 1.48 to 4.75. Any pulse deficit. 28.6, 25.7, 37.8, 0.56, 0.6, 0.03, 1.75, 1.06 to 2.88. From Rampold AV, Trimarchi S, Eagle Ka, et al., Simple Risk Models to Predict Surgical Mortality in Acute Type A Aortic Dissection, the International Registry of Acute Aortic Dissection Score. And Thorax Surge 8355, 2007. Uncomplicated Acute Type B Aortic Dissection. Drug treatment alone can result in 78% 3-year survival. Medical management remains a gold standard. Endovascular treatment is increasingly possible with low mortality. IRAD, New Insights into an Old Disease. JAMA 283 to 897, 2000. Adsorb Trial Acute Dissection, Stent Graft or Best Medical Therapy. Acute Uncomplicated Type B Aortic Dissection. Stent Graft or Best Medical Therapy. 250 subjects, 125 tests, 125 control. Follow-up, 3 years. Less than 55 millimeters. Number 30-day death, stroke or paraplegia were reported in either treatment group. Aortic remodeling at 1 year, p less than 0.001, favored TAG plus BMT, complicated acute type B dissection. Complications such as malperfusion, shock mortality rate is 25% to 50%. Conventional open surgery 30-day mortality of 30%. Meta-analysis has shown that endovascular treatment of R-30-day mortality of 9.8%. 30-day mortality in patients with acute type B AD undergoing stent graft placement in comparison with medically and surgically treated type B AD patients derived D from ARAD. Egebrecht H, Wiener CA, Neuhauser M, Baumgartz D, Kish S, Schmerman A, et al. Endovascular stent graft placement in aortic dissection, a meta-analysis. Gerhard J. 2006 27 to 489 to 98, TAVR treatment modality of choice in complicated acute type B AD. Focuses occlusion of primary entry tier. Size of stent graft should be based on diameter of aorta proximal to dissected segment, applying almost no oversizing. Sufficient length, 1.5 to 2 cm, of proximal landing zone. Ballooning is not recommended even if stent graft is not fully expanded. Retrograde dissection and rupture of dissection membrane. Chronic type B dissection. Manage conservatively. 15% complicated by aneurysm. Conventional open surgery has an appreciable death rate and poses considerable physiological challenges. Endovascular approaches associated with less morbidity and mortality. Endovascular surgery 93%, open surgery 79%. Subramanian S., Rosselli E.E. Thoracic aortic dissection, long-term results of endovascular and open repair. Simon Vasc Surge 2009 22:61-8. Instead trial investigation of stent grafts and aortic dissection. 140 patients with uncomplicated type B dissection greater than 2 weeks. Compare drug therapy with endovascular stent grafting. 2 years of follow-up. No difference in rate of death between 2 treatment groups. Patients receiving endovascular grafts higher rate of false lumen thrombosis. Systematic review of midterm outcomes of endovascular treatment. Reintervention for late morbidities. Endoleak, 8.1%. Formation of a distal aneurysm, 7.8%. Rupture, 3.0%. Postoperative surveillance is mandatory. Thrumworthy SG, Cardhike Sailing Vom A, Patterson Bow, Holt PJ, Hinchcliffe RJ, Loftus M, et al. A systematic review of midterm outcomes of thoracic endovascular repair, TVAR, of chronic type B aortic dissection. Urj Vasc Endovasc Surge 2011 42 to 632 to 47. Endovascular therapy in aortic dissection. Fenestration of aorta and stenting of branch vessels. Earliest techniques used in complicated type B dissection. By fenestrating intimal flap, blood flow from false lumen into true lumen, decompressing distended false lumen. Endovascular stenting. Acute aortic rupture, malperfusion syndromes and rapidly enlarging false lumens. Endovascular grafts cover area of a primary intimal tear. Promote false lumen thrombosis. Stable trial. Pedico technique. Entry point is sealed with endograft and remaining thoracic and potentially abdominal aorta is stented open. Decrease chance of true lumen collapse, enhance aortic remodeling, and promote false lumen thrombosis. Zenith dissection endovascular system. Evaluate safety and effectiveness of a unique composite thoracic endovascular aneurysm repair, TVAR. Construct proximal TX2 stent graft and distal BMS, Zenith dissection endovascular system, Cook Medical, for treatment of patients with complicated type B AD. Enrolled 40 patients. Acute 24 binds, 60%, subacute, 15 to 30 days, 6 PTS, 15%, and chronic, 31 to 90 days, and 10 binds, 25%. JVasc Surge 2012 55 to 629 to 40. 30-day mortality rate was 5%, 2 of 40. 2 deaths occurred after 30 days, leading to a 1-year survival rate of 90%. Morbidity occurring within 30 days included stroke, 7.5%, TIA 2.5%, paraplegia, 2.5%, retrograde progression of dissection, 5%, and renal failure, 12.5%. 4 patients, 10%, underwent secondary interventions within 1 year. Favorable aortic remodeling was observed during the course of follow-up. Increase in true lumen size and a concomitant decrease in false lumen size. Completely thrombosed thoracic false lumen observed in 31% of patients at 12 months as compared to 0% at baseline. Hybrid approach. One segment of aorta, such as the aortic arch, is treated surgically. Descending aorta receives an endovascular graft, Zone 3 carotid bypass plus TVAR. Zone 4, TVAR. Zone 3 carotid bypass plus TVAR. Zone 2 ascending aorta bypass elephant trunk extension plus TVAR. Follow-up escape recommendations. Regular cross-sectional imaging of aorta, preferably with MRA, at 1,3 and 12 months after discharge and every 6 to 12 months thereafter, depending on aortic size. All patients should receive lifelong antihypertensive treatment, including beta blockers, with a target BP of 1/128th of a millimeter Hg. Intramural hematoma 10% and 20% acute aortic syndromes. Common in older patients. Clinical picture of dissection. Imaging show no blood flow and false lumen or intimal lesion. Hemorrhage of vasovasorium and medial layer of aorta or hematoma arises from microscopic tears in aortic intima. Most, 50% to 85%, are located in the descending aorta. Typically associated with hypotension. Crescentic or circular thickening of aortic wall with maximal thickness greater than 7 mm on T without intimal flap or tear or longitudinal flow and false lumen. Type AIMH. Hematoma may entirely resolve, 10%. convert to a classic dissection 3% to 14% of cases of descending aorta and 11% to 88% of cases of ascending aorta. Aorta may enlarge and potentially rupture. Management. Surgery in patients with acute IMH involving descending aorta. Aggressive medical therapy is advocated in patients with acute IMH involving the descending aorta. IRAD. In-hospital mortality for IMH according to site of origin, penetrating aortic ulcer. Atherosclerotic lesion penetrates internal elastic lamina media. Associated with variable degree of IMH. May lead to pseudoaneurysm formation, aortic rupture, or late aneurysm. Range from 5 mm to 25 mm in diameter and 4 mm to 30 mm in depth. More common in thoracic and abdominal aorta. 2% to 8% of acute aortic syndrome. 25% of PALS are found incidentally. Typical symptoms include acute chest or back pain, similar to dissection. Imaging show crater-like outpouching with regular edges and setting of heavy atherosclerosis. 80% of patients have some degree of IMH. PAL may stabilize or lead to complications including IMH, distal embolization, aortic rupture, pseudoaneurysm, contained rupture, aortic dissection, saccular or fusiform aneurysm. Management. Ascending PALS are treated with surgical resection. Stable patients with type B PALS. Medical management, with strict follow-up and serial imaging. Refractory or recurrent pain have increased risk of disease progression. Rapid increase in aortic dimension are at risk for rupture, should be treated surgically or with endovascular stent grafts. Indications for surgery or endovascular therapy, imaging. Interval development of hemorrhage. Periaortic hematoma. Expanding pseudoaneurysm and rupture. Increasing aortic wall thickness. Ulcer craters more than 20 mm in diameter or 10 mm in depth. Increasing aortic hematoma. Increasing pleural effusion. More aggressive approach to type B PAL than classic type B dissection because of concern of increased risk of rupture. Relatively focal aortic segment involved, suitable for endovascular therapy. Recommendations for thoracic stent graft insertion. References. The Diagnosis and Management of Aortic Dissection. Sri G. Thrumurthy, Alan Carthaik Salingam, Benjamin O. Patterson, Peter J. Holt, Matt M. Thompson BMJ, January 14, 2012, Volume 344. Aortic dissection prompts diagnosis and emergency treatment or critical. Alan C. Braverman, MDCLEVELANDCLINICJOURNALOFMEGICINEVOLUME 78, and UMBER10CTOBER2011. 2010 ACCF/AHA/AHA.test.A/SCA/SCI/SUR/SES/SVM Guidelines for the Diagnosis and Management of Patients with Thoracic Aortic Disease. Circulation April 6, 2010. Acute Aortic Syndromes. Thomas Heatsai, MD, Christophe Nienaber, MD, Kame Eagle, MD. Circulation 2005 112 to 3802 to 3813. IRAD Registry JAMA February 16, 2000, Volume 283 No. 7. The Investigation of ST grafts and Aortic Dissection, instead, Trial. Christophe Nienaber, MD, PhD, Eagle. Circulation 2009 120, 2519 to 2528. Management of Aortic Dissection, New Classification and Midterm Results. Ding Wai, et al., Division of Cardiovascular Surgery, Zheng Hospital, Xi'an, China. Thoracic Endovascular Aortic Repair, TAVR for the treatment of aortic diseases, a position statement from the European Association for Cardiothoracic Surgery, EACS, and the European Society of Cardiology, ESCAPE, in collaboration with the European Association of Percutaneous Cardiovascular Interventions, EPSI. Martin Graben Wo Diaresis Care 1, European Heart Journal Advance Access published May 4, 2012. Brown-Wild's Heart Disease 9th edition. Hurst, Essay Heart 13th edition.